I thought it's a little like bringing coals to Newcastle after all I've learned over the past few days from everyone here. To digress for a second, it was really a pleasure on Friday and yesterday to meet with all the scientists and the residents. I think the residents got a lot out of our discussion of some of the cases. Our focus, we spent a lot of time talking really about kidney and bladder. So hopefully today I'll be able to pass on a little knowledge about management of high-risk prostate cancer. So, I mean, this is a data that's very familiar to everybody in the room. This is a common malignancy that kills an awful lot of patients. We've seen dramatic changes over the past. Do I have a pointer, or am I supposed to just use the mouse? We've seen dramatic changes with the introduction of PSA, with a dramatic increase in the incidence of the disease, a rapid fall as sort of the pool ran dry, and I think most of us expected that the disease would continue to increase in incidence. However, we continue to see a fall, and I'm not really sure what's going to happen in the coming years. I think that's a very interesting trend. At the same time, we've seen a dramatic fall in the risk of dying of prostate cancer, which I think is quite impressive, along with all the several other malignancies, which we've seen a rather dramatic decrease in the risk of dying of disease. Patients really, this is again SEER data, but patients really present predominantly with localized disease. This is, I think, Caucasians, African Americans, and Asians. And what you can see is the vast majority of patients have localized disease, at least in the United States, and I would imagine Canada is exactly the same. Patients very rarely present with metastatic disease. This is also SEER data from Utah, going back to 1994. And what you can see is while about 15% of patients used to present with metastatic prostate cancer, meaning a positive bone scan or positive CAT scan, now it's decreased dramatically. And, in my estimation, it's probably less than 1% in 2009. This shows death rates for prostate cancer, for different sort of cancers, and you can see with the exception of liver and intrahepatic bile duct cancer, you could see a decrease in the mortality of these diseases for both men and women. The exception is probably lung cancer in women. Importantly, prostate cancer seems to sort of be leading the charge in this respect, with an annual decline of close to 4% in the death rate, which is quite impressive. I think it's probably in large part due to PSA screening, more aggressive surgery, higher doses of radiation therapy, and better systemic agents. This isn't to say that we don't have a long way to go. It simply means that, in my mind, that we've done a pretty good job at the current time compared to our colleagues with other diseases. This is the radical prostatectomy data from Dr. Scardino, Dr. Walsh, and Dr. Catalona, showing really pretty good PSA-free survival, metastasis-free survival, and quite shockingly good cancer-specific survival at 10 years. I mean, we could argue that these are patients, many of these patients who didn't actually need treatment, but I think for almost any cancer, our colleagues, surgical and medical oncologic and radiologic colleagues, would give their eye teeth in order to have cure rates that are that good. So in the PSA era, patients rarely present with metastatic disease. The majority of patients present early with localized disease, and therefore most patients can be treated with curative intent. And so the question is, is there any patients that need to be treated, that have high-risk disease, that need more aggressive treatment? I would argue the answer to that is strongly yes. We tend to focus an awful lot on the patients. This is Pat Walsh's data on the patients who have organ-confined disease, or while they have a positive margin, have low Gleason score. But there are a large number of patients that have, positive lymph nodes, positive seminal vesicles, positive extracapsular disease, positive margins, that have quite a high PSA failure rate at 10, 15, and 20 years. So this is positive lymph nodes, and at 10 years, only about 15% of the patients haven't had a PSA failure. Now, many people say, oh, well, that's just PSA failure. Does that really translate to really adverse outcomes? I would argue yes. This is the observation arm from the Adjuvant and radiation therapy study, Ian Thompson's study from SWOG that was recently published. And what you can see is a high percentage of the patients, so roughly 37% of the patients at 10 years have developed metastatic disease. I would say that's unambiguously a bad outcome. This is Dr. Messing's trial for patients who had positive lymph nodes. And again, at 10 years, you can see that roughly only approximately 20% of the patients haven't developed metastatic disease in the observation arm. So I think adverse pathology not only translates to an increased risk of having a PSA failure, but also an increased risk of developing metastatic disease. It's clearly there's a decrease in the percentage of patients that have high-risk disease as we've entered deeper and deeper into the PSA era. So this is data from Capture, and it would say approximately 16% of patients that present to our offices have high-risk disease, which is a decrease from early in the PSA era when it was roughly a third. And we've seen an increase at the same time in the patients that have low-risk disease. I think there have been some changes in the characteristics of the patients that present. It used to be patients presented who had very high PSAs, and a subset had high Gleason score or a combination of the two. Now the majority of the patients who present are patients that have high Gleason score, Gleason 8, 9, and 10, and the high-risk patients that have present with PSAs of greater than 20 are decreasing dramatically. I would guess now the number of patients I see that present with a PSA of greater than 20 is extremely low. Yet I continue to see patients that have PSAs of 8, 9, and 10. So I always like to think in terms of the patient, and this is actually a real patient, 56-year-old guy, gentleman, came in with a PSA of 3.5, a normal rectal exam, no family history, and a PSA 1 year previously had been 1.4. Underwent a needle biopsy and was found to have Gleason 8 cancer in 2 cores, 80% of those cores. A bone scan and CT scan were negative. I live in a part of the country where pretty much everybody arrives with a bone scan and a CAT scan, even if they have Gleason 6 cancer. In my opinion, for this gentleman, it is actually useful because of the Gleason 8 cancer. However, if he had Gleason 6, I think it would not be. He's really extremely healthy, and the question is what to do about him. The first thing to do is figure out how aggressive his cancer is. So we have multiple different tools at our disposal. For the sake of time, I'm not going to spend too much time on this. I think everybody's familiar with the Parton nomogram, the Catan nomogram. This is the latest iteration of it, published by Andrew Stevenson back in 1996. I think one of the things that's important is they're starting to integrate other factors besides stage and grade, such as the number of cores that are positive, which I think are important parameters that can help us predict how the patient's going to do. So this gentleman actually appears to be doing pretty well. I think this is one of the shortcomings of these nomograms is I would guess this patient has much more aggressive disease than this, but the nomogram would argue that he has about a 75% chance of being disease-free at both 5 and 10 years. I think the amount of cancer in the needle specimens is important. I think they can improve on the current TNM staging, and I think almost everybody who treats a lot of prostate cancer uses this data to try and get a feel for how aggressive the cancer is. I think there are multiple different parameters that have been studied, number of percent of positive cores, total length, percent of tissue, unilateral, bilateral involvement. The bottom line is the more cancer the patient has, the more aggressive the cancer is. So this is data from Steve Freeland and essentially looked at Anthony D'Amico's breakdown of high, moderate, and low-risk disease. And as you can see, that clearly separates the curves. But if you use the percentage of tissue involved, the curves clearly separate more. Another factor that I think is very important is PSA velocity, and this gentleman's PSA clearly increased fairly dramatically over the course of the year. The residents and I talked about it yesterday. If you have a jump of 7 or 8 or 9 in a year, from say 2 to 8, 9, 10, I often think there's something else going on. But if you have sort of an intermediate jump in your PSA from, say, in this case, a 1.4 to a 3.5, I think you have to be very concerned that the patient has an aggressive form of prostate cancer. Most of this data has been developed from Anthony D'Amico, who was really the pioneer in PSA kinetics. Just quickly, this is data from the New England Journal of Medicine. These are the patients that have the high PSA velocity greater than 2 nanograms per ml per year, and you can see those patients are much more likely to have a recurrence than patients who have a slower increase in the PSA. If you look at death from prostate cancer, almost all the deaths from prostate cancer were in patients that had a dramatic increase in their PSA, and essentially the patients who had a very low increase in their PSA were much less likely to die of prostate cancer. In fact, none of them did. I think this does raise important questions, particularly in terms of treatment. Did these people not fail because they were all treated effectively or because they had indolent cancer, the kind of cancer that would never cause them problem. And for this cohort of patients, I mean, we shouldn't get nihilistic about this. We may have actually impacted the disease in these high-risk patients by removing their prostate. And I don't think just because a patient's PSA increased to 2 nanograms per year that you should not treat them, and you should say, look, you've got incurable disease. This is the overall survival data, and I think it mirrors quite nicely the data I showed you on prostate cancer survival, indicating, again, the patients with an increase of greater than 2 nanograms per ml per year are the patients who do poorly. This is very similar data for radiation therapy, showing essentially the same thing. Patients who have an increase of greater than 2 do poorly with radiation therapy compared to those who have a less rapid rise, both in terms of PSA recurrence, prostate cancer-specific mortality, and all-cause mortality. Again, this is a paper from a few years ago from Anthony D'Amico, where he broke his patients down into low, intermediate, and high-risk disease. And this is the results if you look at patients who receive radical prostatectomy, external beam, brachytherapy with neoadjuvant hormone therapy or implant alone. And what you can see is patients do quite well with all treatment modalities if they're in the low-risk group. And we can get into no argument here about who does better, but I would argue that all are pretty poor. I mean, in the best-case scenario at 5 years, I think this is radical prostatectomy. Only 30% of the patients haven't failed. So I think clearly this is a cohort of patients in which we should be embracing multimodality therapy. So again, getting back to if this patient presented to your radiation therapist, I think they'd have absolutely no question about what was the right treatment for that patient, and that would be radiation therapy in combination with hormone ablation. And a lot of that is based on landmark work by Dr. Bola, where they took patients that had high-risk disease. This translates WHO grade 3 to Gleason 8, 9, and 10, or T3 disease and above, and they randomized them to 3 years of hormone ablation with radiation therapy or radiation therapy alone, a pretty good dose of radiation therapy, and by current standards it would be a little underdosing, and they looked at disease-free and overall survival. And again, the combined treatment appeared to do better by a fairly substantial margin than radiation therapy alone if you looked at biochemical-free survival and, importantly, overall survival. And there have been multiple studies that have come along after this that have demonstrated the same thing. And I think the real debate in the radiation therapy community is how long you need to give the radiation therapy, how long you need to give the hormone therapy, not whether or not it's useful. Recent data has sort of thrown a little bit of cold water onto this. Again, boy, maybe Anthony should come and be a visiting professor and give this talk, since I seem to be citing him over and over again. But he had a nice study we published recently in JAMA, where he looked at a randomized study of 206 men where they gave them radiation therapy and radiation therapy plus androgen deprivation therapy. And he stratified them by comorbidity using an instrument called the ACE-27. I'm going to come back to that for some data that we did for surgery and radiation therapy. Again, it's a very good instrument at sort of highlighting who's going to die and who's not going to die from their comorbid disease over the next 5 to 10 years. And I think one of the things that's most surprising about the instrument is how what we would think of as not being significant comorbidity, say having had a heart attack a year or two ago, but now not having any angina or something like that, and maybe some diabetes, that will make you as somebody who has a high comorbid condition. And that correlates very strongly with risk of dying of other diseases within the next 5 to 10 years. And quite frankly, if I saw somebody who had a heart attack say a year and a half ago, which had been adequately stented, and he had some well-controlled diabetes, I wouldn't worry about operating on him. And after doing studies using this instrument, I have to say I'm a little more leery of patients that have what I in the past would have thought of minimal comorbidity. I think what's interesting about this study is that the patients clearly did better who got the androgen deprivation than who didn't, and this was a fairly short course of androgen deprivation. If you looked at the patients who had minimal to no comorbidity, you saw a fairly dramatic improvement in the overall survival. But if you looked at patients that had moderate to severe comorbidity, these curves actually reversed. So these are the patients who got androgen deprivation. And the increase in mortality is really attributed to cardiovascular disease. So multiple trials support the use of hormone ablation in combination with external beam radiation therapy. for Gleason 8 through 10 disease and T2C through T4 disease. The benefit is not seen in low-risk disease. I think that we really have to wonder whether or not comorbidity should influence our decision to use androgen deprivation therapy in these patients. And I do know radiation therapists are increasingly deciding not to use it in combination based on the concerns about cardiovascular disease. I think it's unclear whether this benefit is from synergy or just simply from the systemic treatment. So what about surgery? So the first thing I think we have to ask is surgery reasonable? I would argue yes, but here's a little bit of data to help support that argument. This is a study from Memorial Sloan Kettering, roughly 5,000 patients, and they classified their high-risk disease in 8 different ways. I mean, every paper you read in the literature classifies it slightly differently. And as you can see, the definition you use clearly influences how the patients do. So 8, which would be the ones that did the best, are patients with a PSA velocity of greater than 2 nanograms per ml per year. So despite the fact this has gotten a lot of press, and I think we're all concerned about those patients that have a rapid PSA doubling time or PSA velocity, those are the patients who may benefit from surgery the most. In contrast, 1 is my patient, a Gleason score of 8 through 10. And I would argue that often you sit there and you say, well, the patient has some Gleason 8 disease, but it's only in 2 cores. That's the patient that's curable by surgery. And this data would make you wonder, at least to some degree, whether or not that's the highest group of patients. The bottom line is I would argue that a large percentage of patients are cured who get surgery at 5 and 10 years, whatever definition of high-risk disease you use. This is data from our institution, roughly 4,000 patients who were treated with curative intent, either with radiation therapy or radical prostatectomy. What we did, we're interested in overall survival. So what we did is looked at factors that we knew were associated from the patient's perspective with overall survival. So age, race, comorbidity, and again, we used the ACE27. And then things that were associated with the cancer causing mortality, stage, grade, PSA. And then we lastly looked at treatment type. This is a slide that essentially looks at the univariate analysis and the multivariate analysis. Let's focus in on here for a second. You can see we were pretty much on the money. Age was associated with poor survival, comorbidity, Gleason score, PSA was PSA, treatment type, interestingly, with patients who got surgery doing better, and then T-stage and race were not, though they were significant in the univariate. So we created a nomogram, and I think what's interesting in the nomogram, a couple of interesting things. The first thing is that treatment, patients who had surgery appeared to have a better overall survival than patients who received radiation therapy. I think that for patients that had Gleason 7, 8, and 9, there was clearly a strong association at 10 years with survival. I mean, we're commonly taught that patients do well at 10 years no matter what our treatment alternatives are, and this would argue that patients that have high Gleason score disease should be treated aggressively, I would argue with surgery, but radiation therapy as well. In other words, I think pretty much anyone who has a 10-year life expectancy should be managed quite aggressively. And I think that's in keeping with recommendations for watchful waiting and for active surveillance. One of the criticisms of this study was, well, patients who have more comorbidity tend to undergo radiation therapy. So what we did is culled our data set down to patients who had absolutely no medical problems. So they had 0 medical problems. They had nothing else wrong with them. And we looked at age, race, stage, grade, PSA, and treatment type. We found very similar results. So again, age of diagnosis was associated with the risk of dying. Ethnicity, which is kind of sad, was associated with the risk of dying. I mean, this may be, that's a separate talk in and of itself, but that clearly is a problem. Gleason score was clearly associated with it. PSA was not. Stage was not. It fell out, but still radiation therapy was associated with a higher risk of dying. Not necessarily prostate cancer, but dying in a statistically significant manner. So I think the key issue is what sort of therapy to give after the surgery if you're going to treat a patient with surgery. And really the backbone of this is the study by Ed Messing, published most recent update in 2006, looking at roughly 100 men who were treated with hormone ablation either immediately or a delayed hormone ablation when they developed metastatic disease. And at 12 years follow-up, you find there's an improvement in the immediate treatment arm, both in terms of overall survival and disease-specific survival. And I think appropriately they concluded that immediate hormone therapy improves survival in node-positive patients. This is the Kaplan-Meier curves, and if you look, the proportion of men who were disease-free, a rather dramatic separation in the 2 curves. The prostate cancer-specific survival was a fairly dramatic separation. And lastly, overall survival. Now, clearly, the overall survival is starting to get closer and closer together. That probably just reflects the fact that, eventually everybody dies. I mean, prostate cancer is, by and large, a disease of the elderly. And at 12 years, I don't think we can be surprised that many of the men who were diagnosed with metastatic disease have just died of natural causes in both arms. The study was clearly heavily criticized for poor survival in the delayed treatment arm. I think the real issue is the androgen deprivation was given at the time the patients developed metastatic disease in the control arm. And if you gave it, PSA is an incredible rheostat for whether or not the cancer is recurring. And if you gave the hormone ablation at the same time that the PSA just started to elevate, would you get just as an effective treatment and spare 10, 15, 20% of the patients androgen deprivation therapy. I think also importantly, it's unclear if the data on node-positive patients can be extrapolated to other high-risk populations, but clearly it raises the possibility. I think the other large study that bears discussion is the Bicalutamide early prostate cancer program. This is an international trial, essentially looking at roughly 8,000 patients, a variety of different stages of disease, and they gave them 150 milligrams of Bicalutamide or placebo. The primary endpoint was progression-free survival, not a PSA endpoint. I'd like to just focus on the roughly 4,000 patients who had radical prostatectomy. These are the Kaplan-Meier curves, and what you can see is this is actually, believe it or not, a statistically significant difference between the two at 5.5 years favoring the Bicalutamide arm. I think this raises the whole issue of statistically significant versus clinically significant. I mean, to my mind, that's a factor of how many patients you actually have enrolled in your study. If you look at high-risk patients, these are T3 disease and Gleason 8, 9, and 10, you see a little bit more separation of the curves. Again, maybe justifying this a little bit more in patients who have higher risk disease. If you look at progression-free survival, okay, and you look at the entire study, you can clearly see a benefit to the Bicalutamide, even in the radical prostatectomy arm, though not in those who have just localized disease. It's simply seen in patients that have locally advanced disease. However, if you look at overall survival as opposed to cancer-specific survival, you see you don't see any benefit in the cohort as a whole. And if anything, the patients undergoing radical prostatectomy appear to do a little better in the patients that got standard of care, meaning no androgen deprivation. I mean, from a patient perspective, yeah, it's nice not to die of prostate cancer, but ultimately what they care about is whether they're alive or dead, 5, 10, or 15 years later. And it doesn't really matter if you die of prostate cancer or a heart attack. I think this is one of the reasons that this has thrown a lot of cold water on this idea of giving androgen deprivation, or I should say weaker androgen deprivation in this patient population. So there's no discussion of how the PSA failures are managed in the control group in this study. No improvement in survival to date. I think, as I said, we need to wrestle with the issue of statistically significant versus clinically significant. If I do my math right, you're going to have to treat 55 patients to benefit 1, or about 2% of patients. Now, importantly, in the breast cancer literature, and I really don't want to cite the breast, it's always dangerous to have a urologist cite the breast cancer literature, but most studies in women, or a lot of studies in women, demonstrate benefits of this magnitude, and yet almost all women are willing to be treated with adjuvant therapy, so maybe it's a male perspective, but it seems like an awful lot of patients to treat for a small benefit. And it clearly had high adverse effect profile, with about 25% of the patients withdrawing, primarily because of gynecomastia and breast tenderness. But clearly it has the potential to be tamoxifen of prostate cancer, and I hope they continue to follow these patients so that we can continue to get data as to how they do. So do we have effective systemic treatment? I would argue yes. I would say these are small studies, however, with relatively ineffective agents. I mean, Bicalutamide is a fairly ineffective anti-androgen. I think it was very interesting to hear the work that's going on here, trying to come up with better anti-androgens. I think that's clearly something that is of interest. I think it does demonstrate a survival advantage, but I think we need more effective agents and better risk stratification. Who's actually going to benefit? In the Bicalutamide study, so essentially put everybody on trial, and I think in some ways that was an error. So what about adjuvant radiation therapy? I think this is one of the big debates that's going to be going on in the next few years. SWOGs, a study, 425 patients. exactly the patients we're worried about: patients with positive margins, patients with positive seminal vesicles, T3 disease, a fairly decent dose of radiation therapy, and importantly, the radiation therapy was delivered within 4 months of the radical prostatectomy. I don't think this is really important for the discussion we're going to have today, but I think as the debate moves forward, what we're going to find is, how radiation therapy is delivered is not going to be within the 4 months at our institution. They'll never give radiation therapy that soon because of concerns of sort of cementing the incontinence and the impotence at that point in time. Their primary endpoint was metastasis-free survival, but they were also interested in the other important secondary endpoints, and it was just published with their 12-year follow-up. This is the metastasis-free survival. I mean, clearly, for the first time, a benefit for the adjuvant radiation therapy. So that's the adjuvant radiation therapy. That's the salvage, or I wouldn't even say salvage, since when they delivered the therapy afterwards was not necessarily radiation therapy, and it was not necessarily given until the patient developed metastatic disease, but clearly a benefit in terms of metastasis-free survival, and importantly, a benefit in terms of overall survival. So, I mean, this is fairly, I think, important data. Clearly, there's an adverse side effect profile. This is the data from their original publication, but you can see that overall there was a higher side effect profile in the patients who received radiation therapy. There's rectal complications and urethral strictures were the primary ones. Total urinary incontinence, the p-value isn't significant, but I think that's a fairly dramatic difference between the two. And in many cases, this may be because the radiation therapy was delivered so soon after the surgery. A companion study is being done in Europe. They're a little lagging behind. Their follow-up isn't quite as long. It's essentially the same group of patients, slightly more widespread delivery of the dose of radiation therapy, and they have very similar primary endpoints. The question that is being raised right now is which patients are actually going to benefit from this. So this is the data from the EORTC, and essentially what it shows is the patients who benefit the most are those who have positive margins. Patients who have no extracapsular disease, that would be T2 disease. Patients who have positive or negative seminal vesicles appears to be similar for both, and then maybe a slightly higher benefit for patients who have low Gleason score. So, I mean, if I'm putting all these together, my interpretation of this is Gleason 6 cancer in which is an iatrogenic positive margin, and those are the patient population that probably I worry about the least. And essentially, if you did it by Kaplan-Meier curve, this Kaplan-Meier curve are the patients that have positive margins. Those are the group that appeared to benefit the most. Now, the SWOG group actually found very different results. So they found it didn't really matter what your PSA was. Okay, they found that the group that benefited the most were those that had higher Gleason score. And they found that it didn't really matter whether you had positive margins or not, or seminal vesicle involvement. Now, that what they didn't have in here that I think is important is the T2 versus T3 disease. In other words, the iatrogenic positive margin versus the non-iatrogenic positive margin. But I really think there's going to be a lot of debate about which group of patients are actually going to benefit from adjuvant radiation therapy. It also doesn't, neither of these studies really address the issue of whether you could do just as good a job by delivering the radiation therapy just as the PSA starts to go up. This is an interesting study published last year from the Hopkins group looking at patients who received no salvage therapy versus salvage therapy and radiation therapy versus salvage radiation therapy plus hormone therapy, and essentially found the patients who received salvage radiation therapy did better than those who did not. A threefold reduction in risk of death. So we're not talking about a PSA endpoint. We're talking about whether they're alive or dead. The benefit was predominantly seen in patients who had a rapid PSA doubling time and an early recurrence. So I think you're all fairly familiar with the Pound data. Those are the group of patients that appear to need additional therapy the most when they fail because they have the highest risk of dying over the subsequent years. So I think that's important data. Clearly it's retrospective. It's not a prospective study. So it clearly doesn't carry the same weight as the SWOG or the EORTC study. So adjuvant radiation therapy, I think the data is accumulating that it's effective in high-risk patients. I really think the debate as to whether it's useful or not is over. I think the debate is now going to center on who's going to get it and when they're going to get it. I think it doesn't, we have to decide, does it need to be given to all patients? Should it be given in the salvage or adjuvant setting? And the estimates of how many patients it would take to do a trial and prove that salvage radiation therapy was as good as as adjuvant radiation therapy would take 8,000 subjects. So on one hand, that provides a barrier, which would say to me that's going to be a fairly hard study to do with that number of patients. It would also argue to me that the benefit is probably very small, because if everybody thought that the benefit was going to be high, they'd be saying that you could prove it with a much lower number of patients. And this is the data that's come up with from SWOG that was published in their study. So what about chemotherapy? Clearly the Canadians should be given most of the credit for getting chemotherapy really restarted in the treatment of prostate cancer. This is the Antanix study. CLGB did a very similar study with, I'm blanking. That's terrible. Anyway, the CLGB did a very similar study, with, basically these studies, both of them demonstrated no survival advantage for mitoxantrone. However, it was superior in terms of frequency and duration of pain relief, so therefore it was approved. And the question was raised, could earlier treatment actually improve survival? This is a study from Britain, where they took patients that had high-risk localized disease, M1 or M1 disease, and they randomized them to either receive hormone ablation or hormone ablation plus mitoxantrone. A fairly small study, 47 patients in one arm, 46 in the other. And for the patients who had metastatic disease, clearly there's no benefit to the patients who received mitoxantrone. These curves, there's no benefit. But for the patients who had just T3 and T4 disease with no evidence of metastatic disease, there was a fairly dramatic separation of the curves in this phase 2 trial, favoring the patients who got mitoxantrone. So as a result, the SWOG and CLGB came up with a large study taking patients who had underwent radical prostatectomy and were found to have high-risk disease with a Gleason score of greater than 8, T3b disease, T4 disease, or M1 disease, positive margins, or, this complex criteria. Neoadjuvant androgen deprivation was very popular back then, and so they included criteria to capture those patients, and an undetectable PSA. So in contrast to the SWOG adjuvant radiation therapy, where PSA really wasn't an issue when they started the trial, and about a third of those patients had elevated PSAs, this truly was a trial that was designed to be adjuvant. Patients had essentially no evidence of disease. And they were randomized to receive combined androgen deprivation versus combined androgen deprivation plus mitoxantrone. Now, this trial was supposed to enroll 1,300 patients and enrolled just over 1,000 patients and then was closed because of 3 leukemias. So I shouldn't say that, myeloproliferative disorders. That was a known side effect of mitoxantrone. I think that in many ways it's a shame. I think if you're truly going after a high-risk disease and the cost is a few more cancers of another type, I would say that's a price that is worth paying if it truly helps patients. They're clearly they're continuing to follow the patients, and so hopefully, it's a lot of patients, it's 1,000 patients, and I often look at the data from Ed Messing, where he was essentially able to move the standard of care with 98 patients, and my hope is that this study with 1,000 patients will be able to do the same thing. Following up on the mitoxantrone trial for hormone refractory prostate cancer was 2 studies that looked at Docetaxel, an industry-sponsored trial that looked at compared mitoxantrone and prednisone to 2 different dose regimens for Docetaxel, and then a SWOG trial run by Dan Petrolak, essentially comparing Docetaxel and prednisone to Docetaxel and estromustine. This is the data from 327. I could have used Dan's data just as easily. I'm going to take out the weekly Docetaxel, and essentially you saw a survival advantage for the Q3 week versus the mitoxantrone, which translated to about a 2-month survival advantage. Not a home run, but still statistically significant, and translates to a 24% increase in survival, which if somebody said to me I could live 24% longer, I think that I would jump at the chance. Importantly, the quality of life improved in the patients who received Docetaxel, which I think is important since, you don't want to give patients that have a rather limited life expectancy a drug that's very toxic, and therefore it became the new standard. And the question that was raised not only by me but by others, including many at this institution, would earlier treatment improve survival? So the study that I was involved in was a multi-center study involving 9 different institutions, taking patients who had high-risk prostate cancer after radical prostatectomy, giving them weekly Docetaxel, and the endpoint was a PSA of 0.2 and rising. So this was the thing we were actually interested in on paper. I think in reality what we're interested in is whether or not urologists would actually enroll patients in a trial like this. And the answer was an unequivocal yes. We enrolled about 76 patients in about a year and a half. So the toxicity was fairly good. This is a patient who actually died. He had a history of peptic ulcer disease, and he bled from his GI tract. So probably he should not have been on the study. I mean, that's one of the reasons why you do phase 2 trials, because you actually learn an awful lot about who should or should not get the treatment. Most of the other high toxicity was hyperglycemia, which responded quite nicely to essentially stopping the treatment. At a median follow-up of 28 months, 4 patients had died of prostate cancer. This is actually higher now. I think that simply reflects how aggressive the cancer actually was. Fully 60% of the patients had progressed, and there was a median progression-free survival of about 16 months. And Mike Catan modeled how we thought the patients would actually progress, and in his model, they should have progressed at a median of about 10 months. So this is the observed versus the predicted. This is telling what the median is, and as you can see, there appears to be a benefit compared to historical controls. So as a result, there was a large randomized trial called TAX-3501, which was implemented. The design was actually not a 4-arm trial. It was a 2x2 factorial design. So the idea was you can look at androgen deprivation versus docetaxel and androgen deprivation, and we're also looking at early versus late treatment. And the idea is that you could see whether or not you need to treat the patients right away, or you can wait until they have an elevation of their PSA to about 0.4 and treat them at that point in time, and whether you can do just as good a job as a progression endpoint. And also you'll get to test whether or not docetaxel adds anything to androgen deprivation therapy. So this trial was also closed. The reason given was because of poor accrual. However, we were accruing about 30 patients a month, which is more rapid than pretty much any other trial that has been done at this stage of prostate cancer, including the trials that I was citing before from SWOG. I think their real issue was one of patent life. At 30 patients a month, by the time the study was finished, the company wouldn't be able to, their patent life would have expired. I think importantly also the data on SWOG, the adjuvant SWOG trial for radiation therapy wasn't out at this point in time. I think that this trial and the SWOG CALGB Mitoxantrone trial would have to have been closed once the data came out about SWOG as well. Because I think that the paradigm has shifted, and I think that you can't withhold radiation therapy necessarily from these patients anymore. So I think there are a lot of phase 3 clinical trials that are ongoing that are worth supporting. I've cited some of them here. There is no way I've cited them all. I apologize if I've missed any. But I think the VA Cooperative trial is a nice simple trial run by Dan Lin and Bruce Montgomery. Is that right? Yeah, in Seattle. I think this is a trial that really needs to be supported. It's essentially much simpler than the trial that we tried to do, and I think that will help it succeed. I think a simple trial is actually probably better than a more complex one. The CALGB Neoadjuvant trial, James Eastham is the primary investigator on this. You guys have had great success in enrolling patients in that study, and I'd like to thank you for that. Essentially the patients were stratified by risk of recurrence, randomized to get radical prostatectomy versus neoadjuvant docetaxel. I think neoadjuvant treatment for prostate cancer is something that you all here have very much pioneered. I didn't include the data, but I know that recently your data for neoadjuvant docetaxel and hormone ablation was published. And I think that in many ways this not only provides us a way of giving the patients additional therapy, but we'll have a lot of correlative endpoints will help us improve our treatment of patients in the future. And this is a study that's powered for a biochemical free survival. I think the key issue is trying to identify patients who you could do a radical prostatectomy on. I mean, in other words, you want them to be high enough risk, but you don't want to be in a position where it's a patient that you really don't think you should be operating on. And there are, an awful lot of patients like that probably should be referred for radiation therapy, not for surgery, simply because the disease is so aggressive, your chance of curing them with surgery approaches 0. I think this is actually the future. This is a study I actually wanted to do, and while I was sort of getting it together, I realized that the RTOG had sort of beaten me to the punch, essentially combining radiation therapy and chemotherapy. So essentially, they're patients who received a radical prostatectomy within 12 months. have a reasonable Gleason score at the time of prostatectomy and an undetectable PSA, or a slightly higher Gleason score and T3 disease, or I think this should be or T3 disease. Their endpoint is a PSA of 0.4 or greater at 3 years, and essentially they're giving the patient 6 months of androgen deprivation therapy in combination with radiation therapy, and then afterwards they're giving them docetaxel. So the idea is that you're combining both systemic agents and additional radiation therapy. So I think clearly open trials needed to be supported that adjuvant and neoadjuvant systemic therapy works or doesn't work. I mean, I think one of the problems we have right now, at least in the United States, is that people tend to give the patients adjuvant treatment, particularly systemic treatment, without any thought that they might be actually doing the patients harm. It may not work. It may actually cause the patients more harm than good. And then lastly, I think closed trials need to be followed in order to provide data on systemic therapy efficacy. I think this is our future. This is the data on breast cancer, colorectal cancer, and lung cancer. All of them have similar responses in the metastatic setting to prostate cancer for chemotherapy. And the survival in the metastatic setting is very, very similar. However, if you look at these three diseases, have all proven to have a survival advantage if given in the adjuvant setting. It was fairly dramatic, and yet we have no idea whether this is true in prostate cancer at all for any drug. And I think one of the big issues that hopefully you get out of this talk is I'm not sure that one size fits all. So if you have a patient with, this is hopefully the future, you have a patient who has prostate cancer, you go ahead and remove his prostate, and he's either going to be cured, he's going to have occult local disease, occult systemic disease, or both. And my hope is that we'll be able to do a better job of identifying which one the patient has, and then giving either radiation therapy, systemic treatment, or both, depending on where the disease remains. So in conclusion, patient population exists, which I think can't be cured by radical prostatectomy alone. I think that post-radiation therapy, post-radical prostatectomy radiation therapy is effective, and I think the debate really needs to be now whether it should be given in the adjuvant or the salvage setting. I think systemic treatment with poor activity, by that I mean androgen deprivation, has proven efficacy in patients that have high-risk disease, and I think that better systemic therapies are continually being developed, and that we need to try and include these in our armamentarium. And I think these systemic agents need to be studied in this adjuvant setting to prove that they're useful, because at the current time, other than androgen deprivation, none of them have really proven to be useful, simply because they haven't been studied adequately. And that's it.